Hello, today we will dive into the topic of bradyarrhythmia. Before we start, I would like to introduce myself. Hi, my name is Alicia Effendi and I am a student currently taking Bachelor in Cardiovascular Technology. Let's start with the heart's conduction system. The heart's conduction system consists of the SA node, the AV node, the bundle of His, and the Purkinje fibers. The SA node acts as a natural pacemaker and initiates all heartbeat. It also determines the heart rate, and electrical impulses spread throughout both atria and stimulate them to contract. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The SA node receives signals from the SA node and passes them to the bundle of His. The bundle of His is divided into two, which is the left bundle branch and also the right bundle branch, which conduct the impulses toward the apex of the heart. The signal is then passed to the Purkinje fibers. Then, it turns upwards and spread throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of ECG. ECG is a composite recording of all the action potentials produced by the nodes and the cells of the heart. Each wave of the segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave. Atrial contraction or atrial systole starts about 100 milliseconds after the P wave begins. PR interval measures from the start of the P wave to the start of the QRX complex and represents the time between atrial depolarization and ventricular depolarization and reflects the conduction through the AV node. The QRS complex represents the ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles, and S wave represents the last phase of the ventricular depolarization toward the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRX complex. The ST segment reflects the plateau of the action potentials in the ventricles. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation or ventricular diastole. The cycle repeats itself with every heartbeat. What exactly is bradyarrhythmia? That's what we're here to learn. Bradycardia refers to brady, which means slow, and cardia, which means heart action. Therefore, bradycardia means slow heart action. But otherwise it has a normal rhythm. Now when we talk about bradyarrhythmia, we all know that brady means slow and arrhythmia means irregular heart action or irregular heartbeat. Therefore, bradyarrhythmia is slow and irregular heartbeat.
There are several different types of bradyarrhythmias. Each type has its own causes, but they all result in a slower than typical heart rate. Types of arrhythmia include sinus node dysfunction, also known as sick sinus syndrome. The SA node is often called the heart's natural pacemaker because it sends out electrical impulses that triggers your heart to beat. And underactive thyroid gland, hypothyroidism, can result in sinus node dysfunction, or a disease or defect that affects the sinus node to lead to sick sinus syndrome. The condition is more common as people age, but in many cases there's no known cause. Heart block. A heart block is something that gets in the way of your heart's electrical signals. The block stops the electrical impulses in your heart from traveling as they should. A slow heart rate or skipped heartbeats can result. Lastly, bradycardia or tachycardia syndrome. In some cases, sinus node dysfunction leads to alternating periods of slow and fast heart rates. Atrial fibrillation, AFib, is one of these syndromes.
The causes include trauma or injury to the heart defects, age-related changes in the heart's electrical system, and coronary artery disease. The signs and symptoms include fatigue and syncope, weakness, shortness of breath, and dizziness. Now that we have covered the basics of bradyarrhythmias, let's take a deeper look and explore the different types of bradyarrhythmias and their corresponding treatments. Atrial standstill. Atrial standstill is a rare arrhythmia characterized by the complete absence of atrial electrical activity. It typically arises from fibrosis of the atrial myocardium. This can destroy the atrial tissue, preventing normal depolarization, or severe hyperkalemia, because high potassium levels can suppress atrial activity, leading to standstill. The key ECG features include bradycardia, which is basically slow heart rate due to the lack of atrial contribution, no P waves, which means there is an absence of atrial depolarization on the ECG, and escape rhythm, which means that the ventricles may maintain rhythm via a junctional or ventricular escape rhythm, as the atria are non-functional. Next is AV block. For this one, it's the first degree heart block. First degree AV block is a conduction abnormality characterized by delayed signal transmission through the AV node. It is typically benign and does not result in clinical symptoms. The ECG findings include prolonged PR interval, and every P wave is followed by a QRX complex maintaining atrioventricular synchrony. AV block, second degree heart block. Second degree AV block is a conduction abnormality where intermittent AV node conduction results in some atrial impulses, P waves, not being followed by ventricular depolarization, QRX complex. The ECG findings include some P waves not followed by QRX complexes. Conduction synchrony is maintained in conducted beats. Severity is assessed by using the P wave to QRS ratio. For an example, 4 to 1 block, 4 P waves per QRS is more severe than 2 to 1 block. Lastly, we have AV block, third degree heart block. Third degree AV block, or better known as complete AV block, is the most severe form of AV conduction disturbance, characterized by total dissociation between atrial and ventricular impulses. The key features include the pathophysiology, including complete AV dissociation, which means that atrial impulses, which is the P waves, fail to conduct to the ventricles, or cardiac output is maintained by a junctional around 40 to 60 beats per minute, or ventricular escape focus. And prolonged bradycardia can lead to ventricular filling abnormalities, myocyte stretch, and eventually congestive heart failure. In the ECG findings, it is found that there would be non-conducted P waves, meaning that there is no relationship with the QRS complexes. Junctional or ventricular escape rhythm maintains ventricular activity, and escape complexes are life-saving and must not be suppressed. Now, let's talk about the treatment. Firstly, we have to identify and address any underlying causes. For an example, electrolyte disturbance. Due to this, we can correct the imbalances, for an example, potassium or calcium. Next, medications. We should discontinue drugs that slow conduction, for an example, beta blockers or digoxin. Hypothyroidism. We should treat with thyroid hormone replacement. And high vagal tone. Address conditions causing excessive vagal stimulation. For the temporary management for symptomatic bradyarrhythmia includes atropine, which is useful in vagally mediated bradycardia, isoproterenol, which increases the heart rate via beta adrenergic receptor stimulation, or lastly, dopamine or epinephrine, because in severe cases it can be used to support heart rate and also blood pressure. Next, we have the definitive treatment for persistent bradyarrhythmias, which includes permanent pacemaker implantation. The most effective treatment for significant or symptomatic bradyarrhythmias, especially with AV block or sick sinus syndrome. To conclude, bradyarrhythmia encompasses a spectrum of slow heart rhythm that can range from benign to life-threatening. Effective management relies on identifying and addressing underlying causes, monitoring for progression, and providing targeted treatment based on the severity and also the type of bradyarrhythmia. While mild or asymptomatic cases often require no intervention, symptomatic or high grade conditions may necessitate urgent pharmacologic support, temporary pacing, or permanent pacemaker implantation to prevent complications like syncope, heart failure, or sudden death. Early recognition and tailored management can significantly improve outcomes and the quality of life for affected patients.